Friday, April 4th. House Healthcare, and we are turning back to S28. And we have in Charlie Glisserman, Vermont Network.
Thank you so much. Good morning. Twice in 1 week. What a treat. I'm Charlie Glisserman. I'm the policy director at the Vermont Network Against Domestic and Sexual Violence. Thank you for the opportunity to speak today in support of the provisions in S28 that allow patients to obtain medication abortion through an asynchronous telehealth care appointment through an adaptive questionnaire. Sexual and reproductive coercion is a complex issue, and it is often an overlooked form of abuse. And so we greatly appreciate the committee's attention to their perspectives of survivors and their access to reproductive health care in this bill. Behaviors intended to exert control over an intimate partner's reproductive health, including limiting contraception use, sexual assault, and forced pregnancy, are common. 1 in 20 women in the United States have experienced a pregnancy from rape, sexual coercion, or both during their lifetimes. Research illustrates that survivors' experience of abusive partners interfering with their reproductive health care to influence pregnancy outcomes is also common. Survivors report abusive partners destroying medication abortion after it is obtained, or using or threatening violence when a victim attempts to terminate a pregnancy. Reproductive coercion is one way that abusive partners perpetuate involvement in victims' lives. Abusive partners use pregnancy as a strategy to prevent victims from leaving or remain connected to them through their children. Even after a relationship ends, abusive partners often use custody or other family court procedures to harass, intimidate, or control their former partners. In situations of coercion, accessing abortion care can be dangerous. Asynchronous telehealth care through an adaptive questionnaire provides survivors with an option when a call or real-time chat with a provider is not safe. This timely, confidential care can support survivors in accessing reproductive health care they need when they need it. Thank you for the opportunity to speak with the committee today. I look forward to staying in touch on issues of healthcare for survivors of violence and will be happy to answer any questions.
Thank you. Anyone have any questions for Charlie?
Thank you so much. It's really valuable to have someone lift those experiences up, because I imagine it's really difficult for survivors to talk about their experiences. Do you have any data or numbers on how many victims or survivors that the network works with in Vermont?
I do not have numbers on reproductive coercion that I can think of that are state specific, but it's something that I can ask my colleagues about.
Yeah, and I imagine it's hard to put actual numbers on it, knowing that a lot of survivors probably don't come forward.
Exactly. Or don't recognize those behaviors as reproductive and sexual coercion.
Right.
My only wish was that you'd said.
Yes, of course. I'm so sorry. I'm a little
okay.
behind this week.
No, aren't we all?
Thank you. Thanks for coming in, and thank you for reminding us of why we actually have this piece in this bill.
Thank you so much.
Thank you. Thank you. Okay, so Jen, do you want to come on up?
Yes. Over the.
Yeah.
Okay, yes, let me send it to you. We thought I'd be sending it to you.
Found it, Kristen. So Jen's taken some input from a lot of the testimony that we've heard, and kind of done a little markup. But go ahead.
While we wait for Jen, can I ask Charlie a question? I just thought of. It might be a little outside of the realm of your client base, but I'm curious, like, about what the impact on children when they come into the world through a situation where the birthing parent was forced into having the child by the not birthing parent. I don't know if we call them, but.
Yes, I mean, absolutely. That is certainly a part of reproductive and sexual coercion and can be a really painful experience for the birthing person and their children. It is not something that I necessarily have kind of research and data on, but it is certainly something that happens. And ensuring that survivors have reproductive autonomy and can choose whether and when they have children is really critical for everyone involved in the situation.
Thanks.
Just a quick note, there is a wonderful book that speaks to that and those type of births. It's by Andrew Solomon and it's called Far from the Tree.
There's a great chapter.
Yeah.
Yeah, I asked because I work with a lot of youth and families who have been in situations that were abusive, and I have seen how it affects kids, but I'm not a witness today. So that's why I asked.
Thank you so much for the question.
Thanks for asking the questions. Thank you again.
Yeah, thanks. There's something wrong with the monitor because it's doing this matrix like tracking.
While it does that.
I don't think you see it online because when I watch YouTube, I don't see it.
Not seeing that.
It's like 21st century gaslighting. Yeah. Everyone's like, we don't know what you're talking about. There's no glitch on the monitor.
Hi, Jen.
Good morning, Jen Carter from the Office of Legislative Counsel. But language up.
This is draft 2.1.
Check 1.1. I think it's posted as proposed amendment 1.1.
You point me to the section she's referring to.
Want you to, this is the adaptive questionnaire piece.
Is that what you
Right.
referred to?
Okay.
Then I get it.
Okay.
Thank you.
See that my screen. All right. Okay, so we are looking at some changes that I've shown in markup, and I think this is for discussion purposes. It starts, so the first change, again, we're in S20, an act relating to access to certain legally protected healthcare services. The first change comes in section 2. OPR had asked you, Office of Professional Regulation had asked you to strike the language in the delegation piece about a person who is not qualified, and they wanted to strike out the proposed addition of any combination of training, experience, education, or licensing credentials. So I've done that here and in the Board of Medical Practice statutes, but I don't know if that is something the Board of Medical Practice supports. So I have reached out to OPR to ask if they had talked to Board of Medical Practice, but I have not gotten a response. So I don't know how the communication is flowing there. That had been part of a larger stakeholder group decision to put it in. And I think OPR has since had some concerns and is asking to take it out. I think it would be important to be consistent across the different professions.
Does it substantively change the meaning of what we're trying to say?
I mean, I think it does have a different meaning, whether you say any combination or not. But my understanding from the testimony, the written testimony from the Office of Professional Regulation was they had concerns about, they think it would invite delegation to individuals acting out of scope of their professional licenses or wholly lacking in appropriate licensure. And they said OPR is actively prosecuting licensed individuals for engaging in dangerous medical activity without any medical licensure. They're arguing they're qualified by virtue of training alone, and the activity can therefore be delegated to them by licensed professionals. And they think that the any combination of language strengthens that argument and makes it harder for OPR to protect the public from unskilled, unlicensed medical practice. They also had some suggestions to add to this provision that seemed, I think, in discussion with the chair, like they would require more testimony. And I think my understanding in sort of in the development of this bill is that there was some concern from some of the facilities and other providers that I have not heard this since, but language about making a delegating licensee liable for the actions of the individual to whom they delegated professional responsibilities might have impacts, for example, on medical assistants working in hospital settings. And I'll defer to the hospitals to actually tell you if that's accurate, but I recall there was some concern about putting in all cases, putting significant, across the board liability on a provider for any task that had been delegated. So you may need to look for some middle ground or something.
And that's not language that was in the original bill.
That is not language that was in the original bill. It is from the OPR testimony from 2 days ago. So that is not in the draft you are looking at, but certainly can be added in some form if the committee so chooses.
We choose to expand on.
Right, but it seemed like you needed maybe some more testimony from other parts of the healthcare system about what the implications would be and what would be perhaps an appropriate compromise.
Anyone have any questions for Jen on this? Okay.
Then the next place we had a change in, right, this is in the fetal death report section 6. And there had been interest in changing the reference to woman to patient who's being treated as the result of a miscarriage or abortion. Made that change. Unprofessional conduct. Now we're in the Board of Medical Practice statutes. And so, again, I've stricken any combination of, but that may require further conversation. And then this is my take on the OPR suggestion, and this is in the Board of Medical Practice statute, but it's in both places. This is in relation to the adaptive questionnaire. And OPR had suggested that this be required to be a prescriber-approved adaptive questionnaire. And I just didn't feel like it was clear what it meant for, or what it looked like for a prescriber to approve a questionnaire. So I added, provided, however, that by using the adaptive questionnaire, the licensee shall be deemed to have reviewed the questionnaire and to have determined that it was able to provide the licensee with the information necessary to meet the essential standards of acceptable and prevailing practice. So again, you may want to get some testimony because this is just based on sort of the rationale that was described by OPR about information needed to meet the essential standards of acceptable and prevailing practice.
I think this seems to get to what their intent was.
Right. And come up with another way to say approved that didn't look like it needed to be documented in some manner or sort of at the producer level at the questionnaire.
Daisy and then Leslie.
No, I'm fine.
Leslie.
I think there are other examples of when someone uses a questionnaire, they haven't given approval. So when there's anxiety, questionnaires or depression questionnaires, and they're used all the time, you don't give official approval, you just use it. And by using it, you are approving.
Right.
And
What I'm
that's
trying to get at
consistent.
here,
No, I'm
yeah.
just saying
by- yeah.
it's consistent is my
Right.
point.
Okay, great. So we can,
Any other questions on that? Nice work. Sarah.
thanks, but we don't, but I'm also, open to feedback from your other witnesses if there are changes that need to be made. So I'm not limited to it, but just trying to get the idea out there.
Woody.
Do we know whether the medical association?
Everybody is seeing this right now for the first time, so nobody has agreed yet.
Although I don't believe anyone other than OPR, they wanted the inclusion of provider approved or
OPR suggested some prescriber approval requirement. I don't think you'd heard from anyone else that they wanted that. I think you heard different perspectives from the licensing entities about whether they support this provision at all.
But I asked OPR if using it was implied agreement, and I remember saying yes, that I heard a yes. But
Right,
I'm not-
I don't think they were anticipating a sort of affirmative approval, but I don't think that's clear from the language of just saying prescriber approved. So that's what I'm trying to capture, that concept.
Daisy?
I would imagine that, like with other questionnaires, forms in the field, we would want some form of standardization. And also that lends standard to these forms. So I love this language, but I also wonder if there is a way to, and I don't know where it's appropriate, maybe it's in rules, that we offer some way to do that, to offer a way to standardize the form so that, you know, each like different license of prescriber or whatever isn't adding additional questions to the form or modifying it in other ways, so that we have no way to, you know, use the data, for example, or, you know what I mean? Like, it seems there.
I do, I'm not sure that, I mean, I think these are probably commercial products through the platforms, you know, through telehealth platforms. I'm not sure that there is a standard or I mean, unless the state wants to develop
Yeah,
and require the use of a standard adaptive questionnaire. I'm not sure how to reach that unless you want to set some, well, that'd still be minimum threshold. I'm not sure how to standardize it because it's not a state tool.
Also, I just want to remind that we are, in this language here, we are actually creating an exclusion expressly for the purposes of prescribing for medication to, and so we're really only talking about this particular interactive questionnaire.
Right. And you're creating an exclusion from a broader prohibition.
Yes. So it would not, this language would not extend to any other adaptive questionnaire that may be used, because we're specifically doing it for this one instance.
This is where a provider would not be deemed to have committed unprofessional conduct.
Yeah.
Or engaged in unprofessional conduct.
okay.
It's okay, I don't know if it's okay. Is it okay for me?
Sure, go ahead.
I just wanted to explain how
identify
it
yourself?
works. So, my name's Dr. Linda Bryan, and I am a telehealth shield provider.
Oh.
So, and one of the things that we do among ourselves is we have a best practices committee that's national that all of the different telehealth shield providers participate in. And we, you know, really elevate best practices and agree on them to make sure that we're capturing everything we need to capture in our questionnaire at the beginning, to make sure that our phone follow-up is good, to, you know, for all of the things, which is more than most other practices do for anything, to tell you the truth. So, you know, I don't think we need you to regulate this piece of it, because we really are on top of it and trying to do this as perfectly as can be done. Because it's such a leadered field, and we're so vulnerable to being attacked for anything we do. We are so careful to make sure that what we're doing is complete and good and captures the information that we need, and we do it with the idea in mind that this is being shared in our profession among all of us as we develop what we call our best practices.
Thank you, Dr. Bryan.
And we think it's incredibly important. We're gonna put it in here to make sure
Yeah.
that you have this exclusion. Okay.
Next change, I think, is the same one in, this is in the advanced practice registered nurse chapter. So the same language added on to the end of the adaptive questionnaire. The next, two of the coming up sections are struck from proposed to be struck from the bill only because if we are, the only changes that were happening in this section, this is on the certified anesthesiologist assistant, was that language about not qualified by any combination of. And so if we're not making that change, then we don't need the section in the bill at all. So it would come out if that was the path we took. So that's what this is showing you.
Versus, sorry,
No, go ahead.
versus amending the law only to erase our part.
Well, we wouldn't amend it because it hasn't happened yet. So you would have just a section of existing law in the bill for no reason.
Yeah.
Which then gets confusing about how do we cite whether it appeared in a bill or didn't appear in a, or an act that was enacted. All right, so then I renumbered the remaining sections. Section 10 is on the confidentiality of prescriber information. So you've heard a fair amount about this section. Few changes here, some of which are, again, from OPR's testimony. I thought their point about saying to the extent not expressly required under federal law instead of not expressly prohibited made a lot of sense. So I've made that change. So it would say upon the request of a prescribing practitioner and to the extent not expressly required under federal law, the name would not be listed. That makes more sense. OPR was also interested. They suggested, I think, pharmacy professional instead of pharmacist, but that's not a defined term. So I suggested and sent to them for feedback, but have not heard back, pharmacist or other member of the pharmacy staff. That way it, I think, gets to the same idea, but at least it is maybe more descriptive of who we're talking about. And then instead of, there was talk about what if somebody doesn't work in a facility. So I added, instead list the name of the facility or other setting at which the practitioner is, and then practicing as opposed to employed or as a contract employee.
So this would mean that, let's say there was some form of mutual aid or community-based, like volunteer organization or coalition, or just group of people provided who are healthcare providers, but perhaps for free, like volunteering to help people who are in desperate situations, that this would cover them, because without this change, it says employed or an employee. But if they're practicing, they could be practicing, they could be on the streets practicing, helping people, and this would cover it.
I mean, I think it might be difficult to list a non-setting where someone is practicing, but I think it could be overcome. I think it could say mobile or something. I mean, it could, I think, I don't know, I'll be honest, I don't know how their systems are set up. So I don't know whether they have to only select from an existing list of practice locations. I know you heard some operational challenges from some in the pharmacy field, but hopefully there are opportunities to come up with some workarounds for that.
Yeah, I know that when we bill, we have to pick a setting, like you have to code a setting, but if someone was doing it voluntarily and there was no billing involved, then this would cover them too. So I think that's.
Potentially, this is just about what the pharmacist is putting on the pill bottle. I'm just gonna
Oh,
call
that's
it
true.
that.
So
It's just about the container.
yeah,
So
I don't know how they do that.
Okay, maybe. How do you do it? I gotta ask you, what do you mean by if somebody's doing this voluntarily?
Like, let's say that there was a group of doctors who wanted to help people, and the person, their insurance wouldn't cover the service because they're out of state or something like that. Doctors could still serve the person for free. Like
Walking around on the street?
no, like I said on the street because maybe that was like too provocative for people, but I was thinking, like, let's say a birthing person flees a state because they're being abused there, they're being forced into a pregnancy by someone. They come to Vermont, they arrive at the airport, they come downtown, they're homeless, they have nowhere to go, but a group of doctors someone connects them with them, and they say, oh, the person's like, I need this medicine in 24 hours or else. And the doctor prescribes it. I mean, that's a really far-fetched, dramatic example. But I do think we're going to see people coming here in those kind of dire situations, because I can tell you already there's people arriving in Vermont from other states fleeing oppression, whether they're transgender or they're women who are abused, and they're coming here and they're in really desperate situations and there's people helping them for free. That's why I use that as an example.
And now my question is, hearing that, does this allow that?
So this is all about what name goes on the prescription bottle. So this does not in and of itself address the locations in which medicine may be practiced. But this is saying if the prescriber requests, the pharmacist doesn't list their name, the individual prescriber's name on the prescription bottle, and just says the facility or other setting where they are practicing.
I think what I can say, and a provider could back this up, but under existing law, there is a code for field. And so like, for example, when we do a crisis service, if we meet someone in the park, it might be coded as field.
Right, but this is for the pharmacy.
Yeah, exactly. So I don't know.
Not insurance billing. This
I don't
is
know how
for
far.
pharmacy.
Any other questions about this?
And then again, I've added for the second instance of pharmacy, or the member of the pharmacy staff. All right, then what was section 12? Again, this is the unprofessional conduct for certified radiologist assistant. And if we are not including the any combination of language for the delegation part, then we don't need the section. And then finally, for effective, what would now be effective dates, in talking with the chair, we suggested making the effective date of the confidentiality of prescriber information on medications for legally protected healthcare activity effective on January 1st to give a little more time for the pharmacy industry to figure out how to operationalize that section, and everything else would take effect on passage.
If we have some issues, yes,
You know what? We need this, we need our names off the pill bottles yesterday. I mean, this keeps us at risk, as long as our names are on those bottles, nobody is gonna prescribe from Vermont as long as our names are on those bottles, so we'll just keep prescribing from other states. Because it's not safe. To names on the bottles, that's how the doctor from New Paltz got arrested, is they found her, I mean, she didn't get arrested, how she got charged, they after her, but they charged her with crimes because they found the pill bottle.
I think the concern is that we've heard from multiple different people in the pharmacy world that it's not possible operationally currently. Jessa, did you wanna?
Yeah, Jessa Bonner, Vermont Medical Society. We've been emailing with the Pharmacist Association and talked briefly in the hall with OPR, so we don't have the final solution yet, but we've been talking about an approach that says redacted or otherwise removed as opposed to shall not list. Because the issue seems to be their electronic systems cannot remove it internally. However, you use a Sharpie, scissors, remove it from the label before it's attached. And so if with the committee or chair's permission, we'd be happy to try to keep providing a solution like that it could work operationally for the pharmacists as well.
My concern is that if we make it so that it just needs to be redacted, then we are continuing the operation and not having them adapt their
Records.
way of doing things.
So we could look at a hybrid version where in the shorter term, there's redaction or removal with a delayed, with a delayed effective date for the fixture system.
Yeah. That's what I was thinking.
Okay.
Yes. Good.
You both had your hands up.
Yeah.
There's the-
Jennifer Marquez,
Yeah.
Planned Parenthood of Northern New England. I think that would totally work. Most of the Shield providers do so through a mail pharmacy who already has the capability to do this. The real concern is with the local pharmacies on the ground. And so if we allow for them to redact or have more time to come up with those solutions, I think that
a combination of the two would meet everyone's needs, and Planned Parenthood has a pharmacy in-house too.
Maureen,
Asking the providers in the room, practical, so I like the hybrids. That was going to be my suggestion too, so that we could immediately implement the redaction or cutting. How, practically speaking, when I'm thinking of local pharmacies, and staffing having to do this, we're not talking about huge numbers. So it's not like they're gonna have to hire an additional person.
People a year,
Maybe two people, if that.
a year, two
Okay.
people a year. It's not common. Most pharmacies that don't dispense. Most people are going to Planned Parenthood if they're going in person in Vermont, they're going. And, you know, and also doctors are allowed to stock these medicines and hand them out from the office. So most of the individual providers who do this do stock it themselves and don't send people to a pharmacy because it's impossible to find a pharmacy that carries.
But to be clear, this language also applies to gender affirming, medication for gender affirming care. So it's
That's
not
true.
just reproductive health.
That's true. Thank you for that.
thanks for that reminder.
So
Um, let's go around the room. Christina, did you? That's great.
Thank you. Christina McLaughlin on behalf of the Vermont Pharmacists Association. So just to be clear, as the Pharmacists Association and only one pharmacist has been able to testify on this matter, it is not possible to go into the system and edit and change what is printed out on the table. A lot of these systems are national, it depends on the computer system, and that is a logistical nightmare. So the redaction, we were working with VMS on this language, felt more comfortable. I understand a phase in. I think what our concerns are is an independent pharmacy would eventually need to spend probably a lot of money to change their computer systems to be able to have this potential possibility to take the name off in the system. At the end of the day, we talked about how the systems have to have all of this information. There's billing, there's insurance, there's things that has to be, they're audited. All of this is already in the system. So the redaction we felt more comfortable with. I'll go back to the EPA and see how they feel about the phasing of potentially being able to exist in the system before it's even printed. But I think the main thing here is pharmacists are worried that I've been told they do not get 100% of the information that's transmitted, because again, it depends on the computer system that they're working with and how that kind of connects with other systems that providers are using. And so if a pharmacist does not get the note, because there is no uniform way in language, how this will be requested, that if they miss that note or don't get it, then could they be sued by a prescriber if they're not compliant with this law? And that's really the main concern here. And then even, there's been discussions, and again, we're working with VMS on this right now, but if we're gonna extend these protections to providers, then let's extend this protection to pharmacists, that they should be able to also remove their name from the label. And at the end of the day, the pharmacist's phone number is still on the label. At the end of the day, if this prescription ends up somewhere else, I also wanna just highlight, we can't impact other states' laws. So if someone is taking a prescription or dispensing it out of state, we can't legislate that. And I know the New York provider, that was the case. It was dispensing medication, prescribing to someone out of state. And so I just want to make that note. But obviously, pharmacists are very supportive of protecting providers, protecting themselves, protecting patients. That's something they care about all day, every day. And so they definitely don't want to not do something. They just want to make it known that this is not as easy as we're making it sound. And this is just, I think, disconnected, what they have to do day to day in these systems and the tension between legislating.
I'm just, well, I'd just like to say that I hear you. I hear the concerns. However, our systems don't do it like that now. So therefore, we're not going to do it. Does not seem like a reasonable.
Not that they won't do it. I mean, I think the language matters here. So like we said, the redacting is more feasible. That is something that once the label comes out, If you would like a pharmacist, a patient could also do it, a provider could also do it, depending on the setting, just removing that information.
Which
So
is
they're
why
happy-
a hybrid would work.
Yes, I think our concern, and again, I'll flag this for VPA, so maybe they will feel more comfortable, but my understanding is, I'm thinking of our small local pharmacies that have to implement, changes in their computer systems that will cost money, that will take time, and so I'll find out more information on that and get back to you, and so the phase-in seems appropriate at this time, but definitely needing to understand what kind of administrative burden and cost burden that might bring to these small retail pharmacies. And again, we're not concerned about with Cristo, that is, you can kind of say never really filled or dispensed in a retail community pharmacy. It's the other prescriptions, medications that we're talking about that are more commonly prescribed in those retail settings.
Leslie?
So I'm wondering if we could just remove the complication. I understand it's both populations and just say redacted and not even worry about them changing their systems at all. That we just redact it and that's that.
I guess I would push back of if we don't, and it's not like Vermont is the only state that's dealing with this and that only our providers are thinking about this. If systems need to change, they will only change
If we make.
if we make them
I get
change.
that.
And, I don't think it would require entire new systems. What it would require is enough states and enough pharmacists saying, we need this, therefore, then the systems will change. If we just say, use a Sharpie forevermore, then they won't change. And perhaps they need to change to protect their own pharmacists. I mean, you said that they don't want their names on it. So systems need to change. And if we have to do legislation to make them change, it seems like that's the way it's going to happen because they're clearly not changing on their own.
Fair point.
Okay,
And then Brian.
well, you're right, but I would like to talk to more pharmacists because our small pharmacies are going out now. If we put that burden, another burden cost on them to operate, like you're saying, we'll make them do it. They'll be gone. And we're already losing small pharmacists. So I'd want to hear more from them. And I want to make sure we do it right.
Okay. And this is why I think they're working on,
Well, I'm sure, but to make them do it, I don't know if I'd agree with that.
so let's do that. Let's let them work on some language that they can all agree to. And effective dates and times. And Brian, and then Woody.
Yeah, so just in that vein, I would support us allowing for redactions or other forms of protection. If we're going to start talking about changing the electronic systems they use, like medical record systems, I don't understand the software for a pharmacist the way I do for other providers because but we do share lots of similar platforms that bear with me on this. There is another bill that we're going to be working on in which there's sections related from my first reading of it to electronic systems of healthcare providers like medical record systems, et cetera, that perhaps one idea is to focus in this bill on the short-term solution, which is the redactions and not touch the systems, with an understanding that when we work on looking at how to improve the functioning of the healthcare system and its electronic records or whatever in the next bill we're going to work on, that perhaps we consider studying how to move towards a more unified system in Vermont. And because then, bear with me on this, that if the state asked people to do that without providing support, it is an unfair burden. But if the state said, we are committed over the next 5 years to creating a unified electronic health record system that includes all the things providers need and some way that they pay into the system based on their use of the system, that then we wouldn't be asking providers to change their system now and then change it again in 5 years, but rather work with us over the course of time to change the system for everyone. And then that in the long term would could potentially save costs, and it would save a lot of stress. But I do think we need to do something with redaction right now. So that's just my opinion on it, is perhaps that we consider not making them stress about the systems language if there was an agreement that we could work on the systems change in the next bill, which is all about a state plan and about systems change. That's just my opinion on it. So.
Your point is to add that to my notes.
No, I don't have anything to add.
Daisy, did you?
I just, I think that I would support the short-term suggestion of splitting this up into the redacted and then, allow time for a longer-term fix with the technology solution. But I also just want to point out that I think some of the associations should be working together to advocate to those technology companies that they're working with to do the work to modify their platforms, because we're certainly not the only state dealing with this. And I think there's strength in numbers. And I think the more associations that can work across state boundaries to talk with these EHR platforms and whatever the small pharmacies are working with, there's a lot of power and advocacy for that. And that's one approach I'd certainly recommend folks look at. And as one legislator, I would be happy to support them in doing that.
All right. I would like to make sure that we add pharmacists as healthcare professionals that are protected.
So I think that I'm not sure what's meant by protected, but if we're talking about not having the pharmacist name on the prescription, that's what I'm trying to research under federal law. I'm not sure specifically for controlled substances, but in general, whether that is permissible or not. So there's the language around the prescribing practitioner seems to be, for the most part, I can't find anything that requires the prescriber's name to be on it. There's some inconsistent language between definitions and usage around controlled substances and whether it has to be the individual practitioner or it can be the institutional practitioner. But I have not at all looked at pharmacy or the pharmacist name, and I do think there may be different requirements for that. So I will need time to look at that. And I don't know if there's any hands-on, I don't know if there's information.
I think there may be some gender affirming medications that would be considered controlled substance.
Testosterone is, it's the only one I'm aware of, but that's why the Controlled Substance Act comes in.
Yep.
Testosterone's a controlled substance.
It is because it's a steroid. I mean, it's an anabolic steroid.
Oh, that's so funny.
Okay.
So I think we've landed on,
Linda has.
oh, yes, go ahead.
Just to clarify, what we're really talking about here is the shield law prescribing, which is really prescribing to Alabama, Texas, Louisiana. The little pharmacist in Vermont is probably not often writing a prescription for someone who's taking their medicines back to Louisiana. So would be extremely rare for that situation to arise, whether it's gender affirming care or abortion, because this is shield law prescribing to protect us from those states.
I think it's the dispensing part, the pharmacist's name on the container as the dispenser, not as the prescriber.
Right.
That they're talking about.
Yes, and so they need to have that right as well when we're talking about, but those are mostly mail order pharmacies that would like to take their name off, whether the local pharmacist needs to take their name off the medications or the local doctor. And that's why it's like at request. Like if we request that our names be off, because we don't care if our names are off if we're working in Williston or prescribing to our own patients there, that's fine. It's really for the remote risk of, one of these states coming after us.
I'm getting confused of where everybody is.
Does that mean that
Street.
I'm fine with the redact,
Right.
I'm just trying
But-
to say that in the bigger picture, the
But-
risks to the little pharmacist are not really real.
Even if
That's
we
right.
do this, what is currently in here, we're only amending Vermont law. So,
Only in Edinburgh.
so if you as a prescriber are providing care to somebody in Alabama and you send in a prescription to a pharmacy in Alabama, which I know you're not going to, but, okay, well, let's move away because we are forgetting that this also applies to gender affirming care. But if you as a provider are sending in a prescription to a pharmacy in Alabama, this law isn't gonna cover you anyways. So no pharmacy in Alabama has to redact or remove or anything. So we're not actually able to do that level. So we're really only talking, yes, but you're not. But there are providers who are sending other types of prescriptions to Alabama, or patients, if they're licensed in Alabama, they happen to be here and they have a patient who's down in Alabama, then, you know, we're not just talking about abortion medications.
But gender affirming care also, the concern is if you're sending the medications to a state where what you're providing is illegal in that state, that's when you need protected. And that's when you would not be using an Alabama pharmacy.
Exactly.
They wouldn't do it.
Exactly.
So you're using the Alabama pharmacy that's probably in California to get those medicines to Alabama. And there it's the California law that has to take the minutes off.
Yes, and so for the purposes of this bill, we're really only talking about Vermont pharmacies. So let's focus and keep our goal on what do we need to do to protect providers who happen to be prescribing for a pharmacy that's going to be fulfilling or filling a prescription in the state of Vermont. So let's get the two parties together to work on some compromise language around either removing it or redacting it, and suggested effective dates that will be amenable to all. Does that sound good?
And have Jen work on look at the federal pharmacist stuff.
Certainly if
Yeah.
any of the other stakeholders are aware or have helpful federal citations to send me, happy to look. Otherwise, I'm just going to continue trying to find the right search terms.
And we're leaving out the system stuff for now, changing their systems.
We're going to see what comes back. from-
Okay, all right.
From interested parties.
Quick question. Jen, in your opinion, does Vital have to be involved in this group of people?
No, because we're talking about physical prescription containers.
You know, I thought we were talking about electronic records too.
We are not, I think that was Representative Chena was talking about the integration of clinical and claims data provision in S-126 as a possible opportunity to look at whether there's a role for changing prescribing and dispensing systems. But no, there is no, I don't believe there is a role in this section around filling prescriptions with or without the prescriber's name on them does not involve Vital in the health information exchange.
Okay, I'm gonna use myself as an example. So my electronic record would not, it would show that I'm taking aspirin, but it would not show who prescribed it,
This
or
is
what
just,
pharmacy gave it
this is
to.
just about what you take in the bag you get at the pharmacy that has your prescription bottle in it. What is on that bottle? So it's not about the records that are being kept of whether electronically or on paper. It's really about what is on that prescription bottle that you use and then maybe throw away, and somebody's name is on it as the prescriber.
Yeah, so my electronic record would show that I'm taking aspirin, period.
Yes, this doesn't change anything about your electronic health records. I think the issue that has come up about pharmacists and their systems is what it spits out for the pharmacist, technical term, for the label that goes on the prescription bottle. I'm just gonna call it bottle for use.
We keep going.
Different.
I think it's like a little
Yeah.
I think it may depend what the medication is, and what its purpose is. So I'm just, but on the package you take out of the pharmacy for these types of medications for gender affirming care and reproductive health care, there would be an option for the prescriber to ask that their name not be on the label that comes out of the pharmacist staff's machine and goes on your bottle, prescription bottle.
What do you think?
I would just comment, it's more than just the bottle with the name and information on that bottle. There's also, you get a bag or.
Yes, could be on the printout that comes with it.
Yeah.
Yes, that's why we've used the term fulfilled prescription.
Yeah, just
It's a
the
description.
reason I brought up the systems thing is because we heard that going further than redacting or revising a label might require a change to their systems, and there was concerns about the cost of that. And I brought that up, Topper, to be like, if we're gonna talk about systems change, let's save it for later and not get into that now, and just allow them to revise and redact without messing with the system. I would never support a medical record not including information that's confidential about prescribers, because you need that internally. And that's really not what this is about. It's about protecting people externally. Like Jen said, when the bag is completed and you're carrying it around, why does that have to have all this personal information on it about people? I think that doesn't, because there's still a confidential record that providers can use to make sure care is being provided within standards of practice, so.
Okay. Good? Yep. Okay. Let's move on.
That's it for the markup. That was the end of the bill. The last issue was just the timing piece, and then that led to conversation.
Okay. So let's work on things over the weekend. Let's come back to this on hopefully Tuesday. So hopefully we'll have feedback with plenty of time given to legislative council, and we'll come back to where everything's landed on Tuesday. And I would like to do markup and possible vote on Tuesday. Brian?
I have a question for Ledge Council that I don't expect answered today, but I want to ask it now.
Anyway.
Yeah, but I want to ask you now because of timing. It's like, why save this for next week? Because then you could, but just thinking more about external versus internal information. Could another state subpoena a person's health record in Vermont and force a provider to turn over a confidential health record in a case where they're prosecuting a provider for providing this care, or do our shield laws?
Right, this is what the shield laws were.
Is it currently protected?
Yes.
I just wanted to confirm
The
that.
shield law
Yeah.
does, and I think, we're continuing to look at whether there are additional protections that need to be tightened up. So that's part of what I'm working on as well, and I'll work with the chair to bring anything that needs to come forward for consideration on that.
Well, thanks. I just asked because it was just coming, we were talking about it and I was like feeling secure. And then I was like, let me just make sure, because this is not about what's
In a
protected.
confidential medical record, and then you
Yeah.
thought, wait a minute.
Yeah, exactly. But this is really about once it's outside of the hands, once it's in the hands of the patient It's just like when you disclose a record to a patient, you say, once this is in your hands, I can't protect it. So if you leave the USB drive or you leave this on your computer and your husband sees it, it's beyond us, you know? Most people don't take their health record for that very reason, because they can't protect it once it's in their hands the way a provider can. So that's why.
And so, I need to caveat the Shield law with, it has not been tested yet. It is the New York law that is about to be tested or is being tested. So we, stay tuned, and there may be additional modifications we need to make. We have, I think, to our knowledge, done as much as we could or knew to do 2 years ago. And we're looking at whether there are additional avenues that we need to pursue through legislation.
Are these federal judges who will be trying these cases if it's interstate like that?
Depends.
Yeah, I ask with concern because I read a story yesterday about how the current administration was punishing judges or something, and like kind of creating a climate in which if judges don't rule in favor of executive branch, so anyway, whatever, we will cross these bridges when we come from, but
Great.
it's concerning to me that the courts could be undermined.
All right, everybody. We're done for the day. So for the week. The day.
Not for the month.
Unless you have to work on a bill.
The
report.
morning.